I just want to say good evening and thanks very much for coming in to listen. And I'd very much like to thank Professor Kingston Mills from TCD coming to present to our student nurses. I'm very honoured to have you here. We've also got Anthony Staines, Gillian Paul and Christine Loscher who are going to be on part of our panel afterwards. But if that's okay with you, the running order is to allow Professor Mills to run through his talk, and then afterwards we'll have a question and answer session, if that's okay. So thank you very much, Kingston.
Okay, thanks very much, Tracy. I'm honoured to be able to present this evening. And what I'm going to talk about are vaccines in general, and some of the benefits, but also some of the risks and some of the myths. And then at the end, I'll talk about COVID vaccines in specifics. Everybody has a different view of vaccines, and it's not everybody who thinks that they're the most wonderful thing, even though I think that they are. And in fact, apart from clean water, vaccines have probably saved more lives than any other medical intervention. There are so many infectious diseases that we have reduced to very low levels as a consequence of vaccination. And but they're not 100% effective, as we know from the recent COVID-19 pandemic. They're not 100% safe. They do have safety issues sometimes. And people have a right to make their own decision, and vaccine has never been mandatory in this country. But the decision must be and should be made on scientific evidence of weighing up the benefits versus the risk. Now, there's a lot of misinformation that has mainly permeated social media, but also various websites of people who look up information on vaccines that will tell you various things about vaccines, a lot of which is not true, that they cause cancer, that they cause psoriasis, they cause multiple sclerosis, autoimmune diseases, autism, etc. And before Donald Trump became president, he was very negative around vaccines, and he did change his tune later, as I'll see in a minute. And he was on the autism brigade of saying that vaccines were responsible for autism. But a lot of this comes from unofficial websites that are not based on sound scientific evidence. And it's really important that the risks must be weighed off against the benefits based on scientific evidence. Why do we need vaccines? We need vaccines to prevent infection with pathogens. These are disease-causing organisms and microorganisms. And these include viruses such as SARS-CoV-2, influenza, bacteria, such as those that cause meningococcus or whooping cough, fungi that cause candidiasis and other fungal infections, and parasitic diseases, which are really a big issue. And we don't have any. We have the first ever vaccine against parasitic disease, against malaria, which was developed or licensed this year for use in Africa. But there's still around a billion people every year that get infected with parasitic diseases that there are no vaccines. And we deal with these infections through our immune system, and the immune system uses a combination of innate and adaptive immune cells. Macrophages you will have heard of. These are phagocytic cells that engulf bacteria, T cells which release cytokines, and B cells which make antibodies. And the antibodies are particularly important in viral infections, and I'll come back to that in a minute. Now, this cartoon illustrates how we get immunity either by what we call natural immunity or through vaccination. Natural immunity occurs when we get infected with a particular pathogen. We get sick usually, but if we're lucky, we will recover and we're immune. Now, obviously, to get immune in this method, you need to get sick and in some cases get very seriously ill and even be hospitalized. But you will become immune. And people who are infected with SARS-CoV-2, particularly the Delta variant, have high levels of immunity against reinfection that lasts for at least 9 months. But that's not a very good way of getting immune because you have to suffer the consequences of the disease. A much better way to do it is to vaccinate. So here you're inducing immune response, but you're not getting the disease, and yet you're becoming immune. So it's a much safer way of getting immunity than through natural infection. And you might have heard people talking about herd immunity. I prefer to use the word population immunity. This is when a threshold of vaccine uptake has reached a level where the whole population is protected. For some vaccines, it's as low as 80%. For others, it's as high as 95%. the recent estimates for SARS-CoV-2 is that it's around 90-95%. So it is quite difficult to reach this. And this is the entire population, not just adults. And so the idea that we're going to reach herd immunity against COVID-19 or SARS-CoV-2 is at this stage fanciful. We're simply not going to do it in the short term, even the medium term. The big deal about herd or population immunity is it provides protection against those that are very vulnerable, who won't themselves mount a response against the vaccine or for whatever reason can't be vaccinated. So it's particularly important in protecting the vulnerable. So what is a vaccine? Well, a vaccine is a weakened or killed pathogen, and the pathogen is a bacteria, virus, parasite, or fungus, or a portion of that pathogen structure called an antigen, or as we've seen with the SARS vaccines, nucleic acid coding for one of those antigens. When stimulated, when injected into the body, stimulates an immune response against the pathogen, but doesn't cause disease. So in the case of influenza, it's the influenza hemagglutinin molecule, which is given usually with an adjuvant, alum or other adjuvants. Now, what happens when this vaccine is injected, the antigens are taken up by these cells called dendritic cells that go to the draining lymph node. They prime T and B cells. The B cells will make antibodies. And in the case of virus infections, the antibodies stop infection. And in the case of fungal infections, it recruits neutrophils to kill the fungi and also with bacteria. And the whole basis of immunity is all around memory. And we get antibody responses which are boosted to the second dose and then they decline, but we retain memory B and T cells. And you might ask, looking at this, why are we having waning immunity against COVID vaccines? Well, it appears that the COVID vaccines are not particularly good at generating memory. And that's why we need to give a third dose. And I'm going to come back to that later. Really, the whole story began with Edward Jenner over 200 years ago, nearly 250 years ago now, with smallpox. It was a disease that killed between 300 and 5 million people in the 20th century. It was lethal in 30% of those infected, so it was a very dramatic virus. And what Jenner did, he discovered that milkmaids or dairy maids who were, in those days it was women who milked the cows, they got cowpox from the cow, and then they were protected. Unknowns to them at the time, they were actually getting a virus transmitted to them through the pustules on the udder of the cow. And that made them infected with the cow version of the virus, which didn't cause disease in the human, but it protected them against the human disease. And then Edward Jenner did an experiment which would never be allowed today. He took the pustules from an infected animal and deliberately inoculated a boy called James Phipps with the cowpox. The boy got cowpox and then was exposed to smallpox 48 days later, and the boy didn't get any disease. And then that started the whole business of variolation, as it was called, of deliberately scarring. And some people who are as old as I am will have a smallpox vaccine site on their arm from the time they got the smallpox vaccine. And of course, even in those days, the smallpox vaccine, the vaccine was ridiculed by a level of the community. And you can see this cartoon with the guy with the bit of a cow on his nose, which is sort of sneering at the fact that the person was being given a virus that had come from a cow. But the bottom line is this vaccine actually eliminated smallpox from the globe. And the last case was recorded in 1977. So that's a huge success story of vaccination. Polio is another very good example. A highly infectious disease caused by a virus that's transmitted by the fecal oral route, invades the nervous system, causing paralysis, irreversible in a lot of people who got it. And you can see all these children that are on crutches because of the paralysis. And they had a treatment in those old days where they put the patients, because they had lung damage as well, their lungs collapsed, and they put them into these iron lungs to stop them from getting lung damage. And this often resulted in death. But An inactivated vaccine was introduced in the 1950s, an oral live one a few years later, developed by Jonas Salk and Albert Sabin, and this resulted in the almost elimination of poliomyelitis. There are only 3 countries, although there was a recent outbreak in another country, 3 countries that were left with polio, and these were Nigeria and part of West Africa, Pakistan and Afghanistan. So these are countries where it's actually been very difficult to cover the entire population because of wars and strife and terrorism, and the difficulty of getting to the people to fully vaccinate them, not because it doesn't work. In the rest of the world, it's been virtually eliminated. We haven't had a case in Ireland for well over a decade. Another one is measles. The impact of vaccines on measles has been dramatic. This is a pretty serious disease. You can see from this boy with measles, and it can cause encephalitis, inflammation of the brain. When the measles vaccines were introduced in Ireland in the 1960s, and then followed up later by the MMR, a combination with other mumps and rubella, you can see that the numbers of cases dropped to virtually 0 in a few years. So it really did work in terms of dealing with this disease. There were a few resurgences of measles in about 10 years ago, and these were around drops in uptake of the vaccine as a result of adverse publicity around other vaccines, and the uptake reduction resulted in mini surges of the infection, but that went away again as uptake increased. And again, it was negative publicity which drove the uptake down, and then once that negative publicity went away, the uptake went up and the disease went down. Now, the problem with the MMR vaccine had been that a doctor in the UK called Wakefield had published a paper in a high-profile journal called The Lancet, showing that giving the MMR vaccine was associated with developing intestinal disorders and autism. But that paper was based on very small sample numbers. It was later retracted, and Wakefield was struck off by the UK Medical Council for unethical and irresponsible reporting of data. And a big follow-up study in the US with much, much larger, thousands of patients, found no link between MMR and autism. But that sort of story rumbled on, in particular in the US. And even people like Robert F. Kennedy Jr. was on a bandwagon about it, and Trump joined that. That's skeptics of the benefits of the MMR and the autism theories. So he was tweeting avidly. Again, this was prior to him becoming president. But they ignored a lot of evidence from very reputable sites, including the Center for Disease Control in Atlanta, which showed there was no association between vaccines and autism. Thimerosal, which is one of the preservative in the vaccine, was also a big issue potentially, and it was shown not to be the causative of autism. And then it was a real, the scientists, and through this journal Nature, came out very strongly in favor of vaccines, and showing that the link with autism was untrue. And in fact, Trump, when he became president, changed his view on this and started saying the exact opposite, which he's prone to do anyway, which was that we shouldn't be listening to this skepticism that vaccines are actually very, very beneficial and don't cause autism. Another one that where a vaccine has had a dramatically positive effect on disease, but also has been the subject of a lot of adverse publicity, is the HPV vaccine, the vaccine against human papillomavirus, the virus that is responsible for most cases of cervical cancer. So cervical cancer is caused when a virus infects the epithelial cells of the female reproductive tract. And it can also affect males, and as you see in a minute, and can also cause mouth and throat cancer in both males and females. But the major worry is cervical cancer. It can be completely prevented by a vaccine, this cancer. There are about 500,000 new cases of cervical cancer each year, and all of these practically are caused by HPV. 7.5% of all female cancer deaths are caused by cervical cancer, or were before the vaccine was introduced. And until recently, there were around 300 cases and 90 deaths each year from cervical cancer in Ireland. And I said males can also get it, genital warts, but also oral cancers, cancers of the mouth and throat. These not very pretty pictures, which will just hammer it home to you that this is a pretty nasty disease that both males and females can suffer from. But the good news is that the vaccine that's been developed is 95% effective at preventing HPV infection and associated cancers. This is some data on the efficacy. This is a really very effective vaccine, between 96 and 100% effective, depending on which grade of cancer you're looking at. And the data on the right in the figure shows some data from Australia showing the dramatic decline in cancer. If you're looking at the light blue line over the period after the vaccine was introduced in 2007. So a dramatic reduction in the women under 21 years who had been targeted as teenagers for vaccination. It's virtually eliminated in Australia in that age group. This is taken from a news article recently from the UK, which showed a 90% reduction in precancerous changes in women vaccinated in their teenage years, and dramatically reduced numbers of cases of cervical cancer in England as a result of HPV vaccine. And the same has occurred in Ireland. But in Ireland, there was an event that occurred, or a series of events that occurred a few years back, which really affected the benefits of this vaccine. And this was to do with various groups that were claiming that the vaccine was responsible for ME-type syndrome. There were, this is taken from a website at the time, groups that had been set up by parents of girls who they claimed had suffered from this chronic fatigue syndrome as a result of taking the HPV vaccine. So that really was bad news for vaccination. Now, large studies which looked at sorry about the typo on the heading. Large studies which looked at this in detail couldn't find any evidence of a link between the vaccine and chronic fatigue syndrome. And this was based on 200 million doses delivered to greater than 75 million people worldwide. So there was no evidence whatsoever that the HPV vaccine causes any immune or nervous system disorder. And both the WHO and the European Medicines Agency conclude the injection is that the vaccine is safe and has no link to serious illness. And this is taken directly from the Irish Cancer Society website. Now, I don't know if you can remember, but there was a lady called Brennan who unfortunately died from cervical cancer, and she was a campaigner in favor of vaccination. And if you look on the slide on the left, the figure, this is taken from the Irish Cancer Society website, where they looked at the uptake of the vaccine in the years. And you can see here, looking at the red and the pink. So the uptake had dropped to close to 50%. So only 50%. It had been at close to 90%, and it dropped to close to 50%. And then it took 4 years to get back to where it was. So this adverse publicity set the system back by 4 years in terms of the uptake of the vaccine. And it was largely a result of Brennan and others speaking out in favor of the benefits of vaccination that turned the tide back in favor of vaccines. She said very clearly that if she'd had the vaccine, she wouldn't be facing a death sentence with the cervical cancer. And that had a huge impact on lots of young women and their parents to go out and get vaccinated. Another one that has been sort of controversy, and some of you might remember this from 2009, 2010, was the influenza vaccine against swine flu. Influenza is a very serious disease, especially in very young children, infants, and older adults. But the flu vaccine is pretty effective. One of the problems is that the flu virus can recombine between humans and animals, including pigs, horses, ducks, and chickens. And the variants that have recombined can be sometimes more pathogenic than the original virus. And this caused a pandemic in 2009 from the H1N1, which was called the swine flu. And it was a very serious flu, and it killed a significant number of people. But fortunately, there were a number of vaccines that were developed against it. Now, one of these vaccines, Pandemrix, was actually associated with, in a small number of cases, of individuals getting narcolepsy, and this was, this also occurred in Ireland, where there was around 80 to 100 young adolescents that got narcolepsy as a result of the vaccine. So this is, I'm showing you this to just, and that vaccine was then taken off the market, and it no longer used. And it was only one of 3 vaccines that was on the market. So something peculiar about this that caused narcolepsy. So sometimes some things can go wrong with vaccines, and this was one example of that. Coming to COVID, we have got a serious problem still, but the good news is that things in terms of the science has come to the rescue, and it will further come to the rescue. We, in addition to vaccines, which I'll get to in a minute, we have other treatment approaches, including antibody treatment. So the antibodies are what the vaccines make, but you can also artificially give antibodies as a type of passive therapy. And they work quite effectively. And there are 2 antibodies that have now been licensed that are going to be used. But the issue with these is they have to be administered early in infection, and they have to be given intravenously. So it's not like rocking up to your doctor's surgery and getting a shot of antibody and you're going to be all right. That's not going to happen. But what might happen is the antiviral drugs, which are much easier to administer. These are now being developed, 2 of them. One by the company America, the other by Pfizer. The Pfizer one looks particularly good, reducing the numbers of hospitalizations significantly by about 7-fold. And it's very good at reducing the viral load. So these are oral drugs. They can be 2 pills a day for 5 days. And they're expensive enough. They're nothing like as expensive as some of the therapies we're currently using in other diseases. So there really are potentially going to be a big impact on next year or later this year. The UK has already licensed the Merck drug. The Pfizer drug hasn't yet been licensed, but it's very likely that it will be licensed very soon. In the meantime, anti-inflammatory and anti-thrombotic drugs, dexamethasone, an old-fashioned steroid, is being used now. Most people who go into hospital are giving steroids to reduce the inflammation, which can kill people, but also anticoagulants to prevent the thrombotic events that can also be lethal, including deep vein thrombosis and arterial thrombosis. So this combination is really reducing deaths in hospital. But really what we want to do is not to prevent deaths, we want to prevent infection. And the best way to do that is through a vaccine. It's the best long-term solution. And it's really the only way that we're going to end the pandemic. We can control it with drugs, but we want to really end it. It has to be the vaccine with other measures. So just a little bit on the various vaccines. First of all, the vaccines that have been developed are all based on the spike protein. So the spike protein is the outer protein on the SARS-CoV-2 that binds to the ACE2 receptor that allows the virus to penetrate cells in the respiratory tract. And antibodies that bind to this spike protein can stop the virus binding to its receptor, and that's the mechanism of how it prevents infection. And the unbelievable news is that around 200 vaccines have been developed. 8 of those have been fully approved, and another 14 have been authorized and are in limited use. And then there's a series of others in various stages of development from phase 1 right up to phase 3. So it's not just the 3 or 4 that are used in Ireland. there are a load of others. And the good news, the last 2 days, a vaccine from Novavax has just gone to EMA for approval, and I'm very confident about its ability to work against infection. So how are these vaccines made? Now, you'll be familiar with some of these vaccines. This is the various way of making vaccines. You can have an old-fashioned way, which is an activated whole virus or whole bacteria, a live attenuated, such as the MMR, the inactivated ones including IPV, inactivated polio, whole cell pertussis, flu, rabies, live attenuated MMR, oral polio, BCG, some types of flu, rotavirus, and zoster, and then subunits where you take a bit of the virus or bacteria and you give it with an adjuvant: diphtheria, tetanus, acellular pertussis, hepatitis B, Haemophilus influenza type B, meningococcus BC, pneumococcus, HPV, the one that I just spoke about, and some of the flu vaccines. So, and then the newest are the recombinant viral vectors. And Ebola vaccine was made. It was never really used in any great amount because Ebola sort of was contained, so it wasn't necessary. And then there are other ones such as mRNA and DNA and peptides. This one has never really made it to the market, and this one has. So in the case of COVID-19, the vaccines are inactivated. These will be very much in China and India, although there is a French company called Valneva that has one now that's in phase 3 trials, and it's expected to be, if it works, to release next year. But the main focus has been on the adenovirus vectors. This includes the AstraZeneca Oxford vaccine, the Janssen or Johnson & Johnson, and then a couple from China and Russia. The Gamal Research Institute of Russia has a very good adenovirus vector vaccine. And then the ones that we probably have put most weight on here in recent months are the mRNA vaccine from Moderna, Pfizer, BioNTech. The one from CureVac didn't work so well, only had 50% efficacy, so it's not really going to make it. And then there are various others that haven't yet got through the various hurdles. And the one I just mentioned, the Novavax one, it's going to EMA approval this week. And the data from the phase 3 showed that it was really very effective. So I've got a lot of optimism around it. How do they work? And I briefly touched on this already. When you inject the vaccine, these are all injectable vaccines. They activate local innate immune cells at the site of injection. These migrate to the lymph node, they prime the T and B cells. The B cells become plasma cells. They make antibody, and as I said, the antibody neutralizes the virus, stops it binding to its receptor. T cells can also have a role by killing virus-infected cells. So there's sort of a dual mechanism of protection, potentially, although the antibodies are probably the key ones at preventing infection. This can reduce infection as well. So, and then some of those cells can become memory cells and then expand again on re-exposure. As I said to you, in terms of, if you look at the efficacy against the original strain, the vaccines were really highly effective, 95% for the Pfizer, Moderna, and also the Novavax. The inactivated Sinovac was, variable efficacy. The Oxford AstraZeneca a bit lower, and the same with the Johnson & Johnson single-dose vaccine. But as you then looked at efficacy against Alpha, Beta, and Delta, the thing was a little bit different. In particular, the AstraZeneca against the Beta strain was only 10% effective in a trial in South Africa, and around 60 to 70 against Delta. I mean, we really are, I dare say it, but we're lucky that it's the Delta strain and not the Beta strain that has taken over, because had it been the Beta strain, I think we'd actually be in a much worse position, because it's a more difficult virus to neutralize than the Delta strain. The Delta is more transmissible, and that's why it has taken over. But in terms of vaccines, it's still affected by these changes that have occurred, mutations that result in the Delta strain. Now, this is data out of Israel, and Israel has sort of led the world in terms of data because they did a deal with Pfizer. And some of you might suspiciously say that, well, can you trust them because they're in bed with Pfizer? But I have to say that the data speaks for itself, and there'll be lots of independent studies done outside of the Pfizer company in Israel that corroborated this data. So what you're seeing here is the infections, hospitalizations, and deaths in the population that have been vaccinated versus the population that have not been vaccinated. You can see a dramatic difference, especially in hospitalizations. It's not so evident here, although there's a huge difference. But in hospitalizations, 39,000 hospitalizations in the unvaccinated compared with 15,000 in the vaccinated. And in deaths, you saw a similar. In Israel, they've estimated that 116,000 infections and 19,000 hospitalizations and 4,000 deaths have been averted as a consequences of vaccination. So that's pretty dramatic. Now, I mentioned the variants, and this is data from the US showing the change in the circulating strains in 2021. What was originally what was called the Californian or Epsilon variant was dominant. And then it became the Alpha variant. Alpha started taking off. That's the English variant. And then when the Delta arrived, it took over. It's the most transmissible. So Delta is now dominant in North America as it is in Europe. Now, this is what happened with the Efficacy. And in the US, never licensed the AstraZeneca vaccine. So they're only using the Pfizer, Moderna, and the Janssen vaccine. Not much of the Janssen, mainly Pfizer and Moderna, about 50-50. This is the drop-off in efficacy against SARS-CoV-2, with COVID disease, in fact, in time for up to 4 months after vaccination. And in red, you have the sort of the dominant variants early on, and in blue, the Delta variant. You can see there's about a 20% lower efficacy against the Delta compared with the original strain. And of course, this is dropping off. It's now around 60% against Delta in the US. And data from Israel showed that it dropped to 50% after 6 months, again with the Pfizer vaccine. So all of these vaccines, and it's not age dependent. And this is where I'm at loggerheads with some of the authorities here, because they're saying that it's only in the older people it's waning. But this data shows clearly, and if you dig into the paper, in the Lancet, it shows that it's clearly, it drops off in all age groups, not just, it drops off more in the older, but it drops off in all age groups. This is another study on waning immunity from the UK, where they compared the AstraZeneca, the Pfizer, and the Moderna vaccine. The Moderna didn't go out as far because they hadn't used it for as long. But again, it's comparing the Alpha strain, which is in these sort of gray colors, round colors, and the boxed ones are the Pfizer. Again, showing drop off to nearly 40% after 20 weeks, 5 months. In the case of the AstraZeneca, the drop off is not as great with the Pfizer or with the Moderna. And the hospitalizations, not nearly as much drop off. And with the Pfizer, it's very little drop off in terms of effectiveness out to 5 months. So it's showing that the vaccine is effective at preventing hospitalization, but not as effective at preventing symptomatic disease. And with asymptomatic disease, it's even less effective. So the vaccines are preventing very severe disease, but not preventing infection. More data on the benefits of vaccination, but also the breakthrough infections. So breakthrough infections are a fact of life. And what this is showing, it's comparing people who were vaccinated in January and February versus people who were vaccinated in March and April. And so the people, the incidence of disease is higher in those who were vaccinated in January and February compared with March and April because of waning immunity, and the same with hospitalization. So hospitalization is higher in people that got vaccinated early compared with people who got vaccinated later. And this was the basis of why Israel decided to go ahead and do a booster, not just for over 60s, but for the entire population. So Israel went from a state that we're in now 6 to 8 weeks ago to a situation where they've dramatically reduced the numbers of cases of COVID again, thanks to the third dose of the Pfizer vaccine. This is showing some evidence of that. So the efficacy was had dropped to 50%. Sorry, that should be 50. 50%, and they reckoned based on the numbers of reductions in cases. So this is fold reductions in the confirmed infection rate. And the bottom line is that the fold reduction is dramatic. So giving the third dose of the booster vaccine, this is the time after the booster. So within 10 days, you're already seeing some effect. And within 21 days, 21 days onwards, you have 16 to 17-fold less chance of getting infected with the third dose than if you didn't have the third dose. So they estimated the efficacy is now at 95% again. Now, there's been a lot of debate here about heterologous booster vaccination. And again, I have been pushing this in the media for months. that we should have been giving people who have the AstraZeneca and Janssen vaccine, the boosters with the Pfizer Moderna vaccine. This shows the benefit of this. This is people who got the AstraZeneca vaccine given a booster with an mRNA, the Moderna vaccine. You can see before and after booster, this is neutralizing antibodies, dramatic increase. Starting with the mRNA, you're on a much higher starting point than you were with the AstraZeneca, but you get back up to almost the same by giving, and it's the same with the Pfizer. So the bottom line is, if you use a single mRNA booster, whether you got the AstraZeneca or the Pfizer or the Moderna early on, you have the benefit. But giving an adenovirus vector booster, you can see here, it's not nearly as effective as giving the Pfizer or Moderna booster. And that points to the benefit of the mRNA vaccine for boosting as well as priming. In terms of side effects, there's not much difference in the numbers of side effects with the two AstraZeneca followed by the AstraZeneca compared with the two AstraZeneca followed by the Pfizer. The same sort of transient mild side effects that you see with each of them is similar. So there's no increase in side effects by doing this heterologous booster. So what's happening right now in Ireland? What's happening right now in Ireland is that every age group, with the exception of the over 85s, COVID-19 cases are increasing. And they're highest of all in the 19 to 14-year age groups. And this is given as per 100,000 cases. So the incidence per 100,000 is 834 for the 19 to 24-year-olds. And this data is up to date about a week ago. And this is from the National Disease Surveillance Centre website. So the 19 to 24-year-olds, which are the secondary or the third level students, is the highest incidence of COVID right now. The 5 to 12-year-olds, which of course are not vaccinated at all, are also very high, and they're the second highest group. Then the 35 to 44-year-olds, and the lowest are the older age groups, which have been boosted now with the third dose of the vaccine. So the bottom line here is that vaccines work, and they prevent. If you boost now, they will prevent further disease, further infections in all age groups. And eventually we will be looking at, I'm sure, of giving them to the 5 to 12-year-olds where the incidence is very high right now in primary schools. This is what happens in country. I don't know if you can see the top of it, but this is a news article from the New York Times recently, which highlighted what's happening in Eastern Europe. In Eastern Europe, there's a lot of skepticism around vaccines, and this comes from the remnants of sort of Russian rule, of autocratic rule, where people were told what to do, and people rebelling against it and saying, I'm not going to have that vaccine because authorities are telling me to do it. The uptake in many of these countries is less than 50%, and this is the consequences. Having to treat patients in gymnasia and other facilities where the hospitals are completely overrun. So we're back to where we were in February and March of the first year of the pandemic in Italy, where hospitals there just couldn't cope. And this is happening now in Eastern Europe. And if we're not careful, we'll head the same way in Ireland. This is some statistics on the uptake of the vaccines in different countries. And Ireland is often quoted as being the best. I don't think it is the best. It's pretty good. It's very good, in fact, at 77%. This is the entire population now. It's 94 for over the adult population, which is good, very good, in fact. But then you look at countries like Slovakia and Poland, the uptake is below 50%. So, and this is to do with skepticism around the vaccine. Countries like Portugal and Spain are the highest, actually. And these are the two countries right now who have the lowest, and Italy, have the lowest numbers of cases of COVID-19. I'm not saying it's direct reflection of the vaccines, but it is having an impact because there are other factors that come into it as well. This is something I just added a few minutes before at the talk. I just got this slide, and it gives the breakdown of the uptake in the different age groups in Ireland. And what you can see is the older age group, over 60s, 99 to 98% between 1 and 2 doses, 95% uptake. So 1 in 100 of people over 80 have not been vaccinated. So 99 out of every 100 have been vaccinated. The same with the over 70s. And then that looks all very good until you come down to the over 18-year-olds. In fact, it's not that great for the 30 to 39-year-olds either. You know, there's 10% of people who have not been fully vaccinated in this age group. And I'm sure there are people listening to this who are in that age group who are not vaccinated. And there are obviously, a significant number in this age group as well, which is as low as 85. So 15% of people are not vaccinated. The 12 to 15 is low because they haven't completed the vaccination yet, and the 16 to 17 is the same. So really, this is the age group where the highest instance of disease is right now, and it's also an age group where there's, apart from the younger cohort, where there's a low uptake of the vaccine. The take-home message, and my last slide. I'm sorry the statistic has come from the US, but it's easier to get data on the US than it is from Ireland. And they've estimated that the US vaccines against COVID prevented nearly 500,000 hospitalizations and nearly 300,000 deaths to September 2021. That's COVID. In other diseases, in the estimate, what would happen today if we didn't have vaccines against polio? It would paralyze 2,000 children. Rubella would cause birth defects and mental retardation in 20,000 newborns. Measles would infect 4 million children, killing 3,000. Diphtheria would be the most common cause of death in school children. And whooping cough would kill 8,000 children, mostly infants. And HIV would cause meningitis in 15,000 children. We must assess the benefit versus the risks, but base this on sound scientific evidence. And when you look at the evidence is clearly in favor of the vaccine. I'll leave it at that. Thank you very much, and happy to take any questions or whatever happens next.
Okay. Thank you very much. That was brilliant. I think our brains are expanded exponentially as well as a result. So really, really grateful. We've actually got loads of, we've got one chat. Oh, do we want to set up as a proper panel now, or are you happy for us just to go with the flow? Would that be okay with everybody?
Whatever you want to do, guys, you're in charge. I'm at your disposal.
Don't say that. The power will go to my head. But just to say that there's a good few questions put, because my students are used to using Padlet with me. So they have some, and it's anonymized, so it's easy to put questions in and not be too worried. But how about if I ask the questions and whoever wants to answer, would that be okay?
Yeah, sure.
Yeah, okay. So actually the first one in the Q&A is, should somebody who got one-shot Janssen vaccine get a booster vaccine before someone who got a Pfizer or Moderna?
I think the Janssen vaccine being a one-dose vaccine, I think it's fairly important that these people get boosted. The data on boosters after the Janssen vaccine in the US are very clear. They showed a dramatic increase in neutralizing antibodies, 76-fold in one study where they boosted with the Moderna or Pfizer vaccine after the Janssen. So it really does boost the response. A single dose after the single dose is very effective at boosting response with the Janssen.
That's good, because somebody else had asked the same question.
Yeah, similar question. That answers both.
So actually here, can vaccines be mixed? As in, yeah. So that's I'd say it's because it's this age group as well that they're really curious, because a lot of them would have had the Janssen.
I mean, there was a lot of resistance amongst the NIAC to mixing vaccines initially, and then they were waiting for data coming from other countries. But so many countries published data on this that they agreed that mixing vaccines was quite acceptable. And in fact, it's hugely beneficial in terms of enhancing the immune response, especially when the mRNA vaccine is given as a second, or the booster vaccine.
Okay. Would people require a booster vaccine every 6 months or so then?
Well, I mean, what's perceived may happen is that we're looking at a yearly vaccine, a bit like flu, where, I mean, I don't want to be alarmist, but and I did say we're lucky in a way that the Delta variant has remained the dominant one, because the vaccines, even though they're not brilliantly effective against, they're moderately effective. If we had the mu strain or the beta strain, we would be in much worse position. And another variant could come along next year or at any stage, and it might evade completely the immunity by the vaccine. So the good news is that the vaccine companies are making versions of the virus, of the vaccines, that are designed specifically to deal with the existing variants that encompass the mutations, not only in the Delta strain, but also in the beta strain. So I'd be optimistic that vaccine will be, available sometime in the new year, and that it would be very effective. So you could perceive of everybody getting boosted with it later next year if they haven't already been boosted with another vaccine.
Okay, thank you. James has asked, yeah, how many more vaccines do you think we'll need before we're all totally safe? I've had my booster.
Yeah, well, who knows? I mean, there's no question. I mean, again, there's a lot of misinformation about the boosters, even from medical experts, saying that there's no benefit of boosters. There's no evidence that boosters are beneficial. Absolutely is not true. I mean, the immunology is very clear on this. We give our children vaccines at 2, 4, and 6 months. They're 3-dose vaccines. That's the normal schedule. They're not called boosters. They're just the primary course is 2, 4, 6 months. I know they're infants and they don't respond as well as adults, but over 80-year-olds don't respond as well as adults either. And they need 3 doses in the same way that an adult will need 3 doses. So there's nothing unscientific about this.
Absolutely. I see Majella Degnan, did you mean to have your hand up and would you like to talk?
I think Anthony wanted to come in there as well.
Anthony had some question there.
Well, you next time, Majella.
I'd say 2 things. I don't think vaccines on their own are going to fix this. The thing people forget about COVID is that roughly 1 in 10 people who are affected with COVID are long-term damage.
Anthony, I can't hear you, so you need to use
Can you speak into the mic there, Anthony?
Yeah.
I can't hear you.
Can you hear me now?
And you should be used to this, aren't you, on the TV the whole time?
Yeah, the microphone keeps changing its sound. Let me just try that. Is that better?
Yes, better.
It's better, yeah.
Better.
Okay, so there's 2 things to remember. I don't think vaccines are going to get us out of this. So the story of COVID response has been a desperate attempt to find a magic solution that would fix it. And the first magic solution was lockdowns and social distancing, and that doesn't work. And the second magic solution is vaccines, and it's really, really clear that doesn't work either on its own. The catch with COVID, unlike a number of other common diseases, is it looks like a substantial proportion of people with COVID are left with long-term damage. We don't know how long-term is yet, but we're going to find out. The implications of that are that there is a huge incentive to stop, to prevent COVID cases, to prevent infection. And infection is, because this is a respiratory virus largely spread through air, prevention includes managing ventilation, includes air filtration. It includes vaccination. Vaccination is incredibly important. And every major infectious disease we deal with is dealt with by vaccination, but no infectious disease has ever been disposed of by vaccination on its own. Infectious diseases are dealt with by a combination of preventive measures of various kinds, vaccination, and serious level public health action. And unless you do all of them, the evidence of this is unequivocal. Unless you do all of them, you don't bring the disease under control. And nobody's ever brought a disease under control by vaccination alone. That may change. We might actually bring HPV under control by vaccination alone. But right now, we haven't. And certainly no disease that is not a sexually transmitted disease has ever been brought under control by vaccination alone. Rinderpest was eradicated with vaccination and intense surveillance and intense veterinary public health measures, and it worked. Smallpox was eradicated with vaccination and surveillance and intense public health measures, and it worked. So bringing COVID under control, vaccines alone will not do it. My guess for the boosters is that what will happen with the boosters is that over time, and hopefully over a longish time, the protection given by boosters will wane. And that is a guess, it's no more than that. We're not going to know the answer to that question for 6 months to a year. But the likelihood is that, as I think somebody has asked, will you be requiring boosters again in the future? The likely answer to that question is, yeah, you will. And if we don't we could have an active vaccination program and high case numbers. And we had that with measles for years. And we paid a very heavy price for it because measles, although it's less damaging, considerably less damaging than COVID-19, a proportion of children affected with measles are badly damaged every year, and a small number die.
Anthony, I'm going to bring you in because you've got students on who've been in college all day, so they're going to go mad if you're actually making it more complicated for them. I think they're actually going to go stay out of the disco all night. So just to be aware, we need some level of hope, and I think that's the idea with this session, is that I was talking to the students today. They're going to have to communicate with the public who are going to ask them all these questions. They need to be able to understand or explain them to their, a part of their role. So I think they're very aware, and these students are very, they've bought into the idea, they've got vaccinated. I can feel their frustration, as you can imagine, that why aren't things going back to normal? I just thought that actually somebody had mentioned something about pregnancy, and I think, Christine, I'm going to bring you in about that, because I think the big concern for females is that their fertility could be affected by vaccines. I think that's been coming through. And then, Gillian, I'm going to ask you, because there is that whole idea of how you convince the public and the general public, how you will manage to get the public to buy into vaccines and not be scared by them. So will I start with you, Christine, if that's okay?
Yeah, and I think one of the most important things Kingston mentioned during his presentation is misinformation around vaccines and their impacts. And I think this is a really classic example of what misinformation can do in terms of damage without any evidence at all to back it up. And you only have to put it out there to sow a seed of doubt in somebody's mind when they are concerned. The misinformation around fertility particularly came from a scientist essentially saying that when you make antibodies to the spike protein after you get vaccinated, that they recognize a protein that's found in your womb called Syncytin-1. And essentially he said, when those antibodies would bind to that protein, it's going to impact on your fertility system. And then what happened was it went out on social media as COVID-19 vaccine is going to destroy your fertility. And then everybody stopped looking for where the information came from and just took it as it was said. There was a group of scientists actually looked scientifically at the biology of how similar the spike protein was to anything, and said it was nothing like any protein found in the human body, never mind this protein about fertility. And I think the really important thing to say about that is that when you get COVID infection, you will also make antibodies to your spike protein. And if it was true that COVID vaccination made antibodies that destroyed your fertility, then it would have to be true that COVID infection would do the exact same thing. And yet nobody is talking about COVID infection wrecking your fertility. So I think that really hammers home the point that if one is true, the other has to be true, and neither of them are actually true. The other thing that's actually come up a lot lately is the reporting of interruptions in menstrual cycles. And again, this is, for anyone who's had a really severe infection at any stage in their life, one of the things that gets impacted is menstrual cycles. They're very easily influenced by any level of stress, the kind of physiological stress on the body with a full-blown immune response after a vaccine. So none of that is unusual. It really doesn't go beyond the first cycle. And there's no evidence that an interruption in your menstrual cycle for a single cycle has any long-term impact on your fertility, regardless of why your cycle might be upset. And it's a normal thing that happens for one reason or another at some stage. So I think that I can totally understand from a young woman's point of view why those two pieces of information might be scary, might be concerning. But I think, it's really important that people look for the sources of the information and ask the question, is it correct? And in these situations, the information about impact on fertility is not correct, and never has there been a vaccine that has impacted on fertility.
Thank you so much, because that's very reassuring, considering the majority of the students are actually female and probably quite concerned about their fertility in the future. Hopefully not during their course, no offense, but let's get them through the course first. Anyway, Gillian, please would you, because as from the public health perspective and with the public health nursing background, how do we speak to our people, the people we're looking after, and explain to them how safe it is?
I think that's a really important issue, Tracey. And thanks, Kingston, for your talk. I think it was really excellent. And I think key to, talking to the public is knowing the information yourself and understanding the information, and getting your information from, scientific sources. like Kingston's talk today. I think, quoting Dr. Tedros, we're fighting an infodemic as well as a pandemic at the moment. And in that respect, like Christine mentioned, there is so much misinformation out there circulating, particularly, I suppose, in other previous pandemics, we weren't dealing with social media. So that's a real issue in terms of circulating information to people. So I think as nurses, we really just have to present information that's correct, that's evidence-based, and understand that people, are anxious, give them literature, backup literature, sources of information that are correct and that are easy to understand as well. I think that's really key. I think a lot of the information I've read around vaccine hesitancy has been around people either being complacent or just not actually knowing the information. So I think nurses have a really important role in that respect.
I did a rookie move there, forgot to unmute. Yeah, and the fact that there's so many nurses in ratio to the rest of the public health or the healthcare workers, we have a real pivotal role. And I think if we're hesitant because we're uncertain, we're not going to be able to convey confidence. So there's a lot of questions. I don't know who'd like to take these in relation to being pregnant. A nursing mother take the vaccine while she's breastfeeding with her child.
Yeah, I mean, maybe I'll just say something about that. Haven't spoken about it previously. The biggest study, going back to what Kingston said, the US is a great source of real world data. And the Vsafe study was one of the ones where they really recorded, first of all, they were the first to give the vaccine in pregnant women. And they've recorded and followed up and done a detailed study on large cohorts of women. And everything that's come out of that study has pointed to the safety of vaccine in pregnancy, the presence of antibodies in breast milk after pregnancy, and the real value of that for protection for a baby or early on in life. So they've said breastfeeding is important. They followed mothers after their vaccines in pregnancy, and there has been, a positive impact instead of a negative impact on the baby. There's no issue with vaccines in pregnancy unless they're a live vaccine, and this is not a live vaccine. So they're the only ones that are contraindicated in pregnant women. We know that there's no evidence that the nanoparticles that the messenger RNA in can cross the placenta. The vaccine is not getting into the baby, but it is a cohort of people who are ultimately trying to protect their baby at all costs when they're pregnant. So they will question everything that they're told to take, and rightly so. And I think that the biggest studies coming out of the US give a lot of confidence about the safety profile in pregnant women, and the studies that show that there are antibodies then to the spike protein for COVID in the breast milk, and that there is some level of protection then for babies. So I think it's very positive news around pregnancy. I think some of the confusion and worry around pregnancy here was that in the first instance, it was only recommended at a certain stage of pregnancy. And that's the norm because, miscarriage happens normally very early on in pregnancy, and you don't want a negative association with the vaccine. So they avoid that usually so that there's no issue, as in there's no negative association. That's not a real association. And they normally would recommend, so the whoop and cough vaccine is after 20 weeks. But now, because COVID has such a negative impact on pregnant women and their unborn baby, they've brought that back to make sure that women are as protected earlier on. And it has been very, very safe. Again, the Vsafe study has shown that. So I think there's a lot of positive news around safety for pregnancy.
Okay. Niamh asked about why the decision is taking so long to vaccinate children. And Anthony has offered to answer that one.
In a way, it's been decided. The US FDA has approved a vaccine for vaccinating children, and that will be rolling out in the United States imminently. The European Medicines Agency is reviewing the same vaccine application, and they will decide at some point. And I'm rather hoping that once they decide, that NIAC will decide very quickly to approve it for use in Ireland, because it's very clear that despite the repeated statement that schools are safe from the minister and from NEPA, that they're not, that children are getting COVID in schools, it is spreading in schools, and the most effective way of stopping it spreading, if we're not going to do anything else, is we might as well vaccinate the children as you said, gives them some level of personal protection.
Great.
Tracey, just to add to that, the data went to the EMA for approval after it went to the FDA. So it's not that the EMA is taking longer. The FDA was, they applied to the FDA for approval first. The EMA have only had the data since the 18th of October, as far as I know. And we're expecting a decision. The news came out this evening. They're expecting a decision by the end of next week.
Okay. This is a good one. As a vaccinated nurse with a recent booster, what is the likelihood of contracting COVID-19 despite all the precautions in a hospital setting? And that's because they're first years and they're anxious, you know, they haven't been out in the wards yet. And there is the fear, naturally enough. What are they stepping into? So I might give that to you, Kingston.
I'm happy to answer that. There isn't a straight answer to it because, you know, you're part of a statistic and you can be unlucky. But the Israel data shows the benefit of the third dose is, you know, 17-fold over not having it. So you have significantly lesser chance of getting COVID than your colleague who didn't get boosted. And Brilliant. The data, in fact, in the over 80s in Ireland is already showing that cohort is now, the numbers are now static or declining. And in the nursing homes as well, where they've vaccinated all the over 65s, the cases there have dropped. So you know, it looks very promising. We don't know how long that will persist, of course, but I'd be optimistic that it will persist longer than the immunity after the second dose, because it's always like that. It goes up a bit in the first, it goes up further on the second, but it goes up even further on the third dose. And that's the way vaccines work. That's just amplifying the memory B and T cells. So the scientific evidence for, you know, the huge benefit of boosters.
Brilliant, thank you. Somebody has asked here, what happened if you've recently recovered from COVID, then are double vaccinated? Is that equivalent to having the booster?
Wow, yeah, absolutely. I mean, especially if they recovered from the Delta strain, because the big deal about the Delta strain is that it's different from the Wuhan strain. So if you get infected with the Delta strain, you actually have very good antibodies against the Delta strain, not against the Wuhan strain. Actually, better antibodies than you would have from the vaccine. So in my view, you don't need to be given 2 doses after having infection, but if you've got them, you've got, you know, heightened immunity, in my view.
Very good, very good. There's somebody's asking, will the booster be required for kids?
That's a good question, and you know, it's a bit premature to be talking about it yet. When you mean by kids, I presume you mean the primary school. The chances are yes, in the long term, but we're talking about like a year away from now. So let's not worry about that yet. I mean, I think that, and you know, COVID is a pretty mild disease in infants anyway, in children, in primary school children. I mean, the big risk with primary school children is more the transmission to vulnerable adults, in my view. So, you know, children getting infected themselves, most of them get very mild disease, but they can transmit and they can transmit to vulnerable adults that mightn't be immune. And that's the biggest risk around, well, you know, there are children. There was a study done in the UK which showed that 4% of children had symptoms that persisted for longer than a month, and 2% of persistence that persisted for longer than 2 months. So it's not a trivial disease in a small number of young children. So that's a very good reason for giving. And as Anthony said, the long-term consequences of COVID is really still unknown, and certainly long COVID, you know, is a real syndrome. And I've spoken to some people on the phone who've had, you know, symptoms for well over a year, and they're still in a pretty bad state. And I wouldn't like to be in their shoes, quite frankly. So if you can mitigate against that, do it and get the vaccine.
Yeah. Greg, one of our colleagues has asked, is there evidence that immunosuppressed people have a good response to the booster or get a good response?
Yeah, immunosuppressed people. So people that are on chemotherapy or other treatments for cancer, or people who are on anti-immunosuppressive treatment for something like multiple sclerosis or rheumatoid arthritis. The nature of these drugs, especially the drug called rituximab, which is an antibody against the B cells that make the antibodies, they're implicated in pathology of certain diseases. So they block them with these antibodies. And Of course, when you're blocking those B cells that cause disease, you're also blocking the very cell that makes the antibody. So it's going to happen that people who are on those drugs will not respond as well. Now, what generally happens is the person's taken off the drug, they're immunized, they generate the response, and then they're put back on the drug. And that can be useful in the case of the autoimmune disease. Obviously, with cancer, that's not so easy to do because you don't want to disrupt the course of life-saving treatment. So these people are more vulnerable because of that. So immune suppression to cancer treatment or autoimmunity is an issue.
Okay, we've got loads and loads of questions. I'm a bit worried we won't get through them all. So if anyone sees any of the panelists want to answer as we go, I do know like this is always going to be a worry for people who are unsure. Is, are you worried about any possible long-term effects of the vaccines as there are so many? I presume you mean so many vaccines. Yeah, I think that was just badly typed. I'm hoping. Yeah, are you worried about any of the possible long-term effects of vaccines as there is so many? I
mean, one can never know. And I quoted the case of the narcolepsy with the flu, but that presents itself, within most of the side effects of vaccines present within hours and days. It is very rare to see long-term consequences. It's not impossible because of the narcolepsy example, which occurred within a couple of months of vaccination, and that was unfortunate. The explanation for it was molecular mimicry between the particular virus sequence and this peptide that controls sleep. So there was a scientific explanation for it. And there was a difference in the sequence of the virus from pigs compared with humans that reputedly responsible for it. But long-term effects of vaccines are exceedingly rare. Most of the consequences are transient, and they tend to be things like headache, fever, and in fact, the people who don't get a little bit of inflammation may not respond as well, because what the immune system is doing when it's responding to a vaccine is activating the innate immune system, and you're getting a burst of cytokines, which are activating the immune system to make the antibodies we need to protect us. So it's not surprising that you'll get a bit of symptom like, a very mild fever. But there are some vaccines that don't cause any of those and yet work. So I think the mRNA vaccines are probably slightly more reactogenic than some of the sort of protein-based vaccines that like diphtheria, tetanus, and acellular pertussis, or hepatitis B or HPV would be milder, but they're not as effective probably. So it's a trade-off.
Thank you, Anthony. You have your hand raised.
Yeah, I mean, the vaccines have been the subject of the most extensive safety studies that have been done on vaccines. And we have identified, because of those studies, some very rare side effects. And the one that people will have heard a good deal about is myocarditis, which is inflammation of the heart after the mRNA vaccines, particularly in young men. And the obvious question is, what happens in young men if they get COVID? And it turns out they also get myocarditis. They just get it much more often. Now, it's the nature of this disease that as long as it remains endemic, pretty much everybody is going to get it. This is about as infectious as chickenpox. And in the absence of a vaccine, every child gets chickenpox at one point or another. So COVID-19 is going to be like that. But the risk of myocarditis, which is the main identified side effect of the vaccine, is much higher with the infection than with the vaccine. And something very similar is true with measles. Measles vaccine is a safe vaccine, but it rarely causes serious side effects. We use it because measles causes the same side effects at a much higher frequency. So measles causes brain damage in about maybe 1 in 5,000 children. It causes brain inflammation in about 1 in 1,000. It causes pneumonia in about 1 in 800. Some children die of that pneumonia. The vaccine can do all of these things, but at rates maybe 100 times less than the virus. So compared with hanging around waiting for the infection, the vaccine is much safer.
Thanks, Anthony. Yeah, that's like the old-fashioned chickenpox parties. That wouldn't be part of the COVID parties either. there was another question actually, and I think this is really relevant. Are there any things in the vaccines that would prevent, that are not, you're not able to give for religious reasons? And I presume that's because there was images of pigs put up. Maybe there's a little suspicion that there's ingredients in the vaccines that may have an impact. Anyone want to answer that one? No. Okay. I think it's to do with there's a lot of wild stories out there that the contents of the vaccines may originate from pork.
This the
No,
kosher thing.
There's no evidence for that. The mRNA is a sort of almost synthetic vaccine. It's not. Okay. It's not. I mean, some of the older vaccines were made, like the flu vaccine, is made in hen eggs, and
okay.
That's where the virus grows best. And others are propagated in cell lines, but the mRNA is a different story. It's sort of almost a synthetic material, so it's free of all biological substances.
Yeah, I think there was just some suspicion that there might be another excuse. It's against my religion, but there's no excuse.
Yeah, I mean,
for
that's the trouble with misinformation on social media.
Yeah.
I mean, those sort of rumors permeate and they get legs, and they're not based on fact.
Yeah.
So it's disappointing when that happens, and trying to stop it is difficult.
And that's why it's really good to have these kind of sessions, because they can ask, and it's anonymous, so they can ask the questions without feeling worried about it. Anyone else have any? I'm just really aware that we're going over. Are you happy to stay on for a few more minutes, or okay? I think we're enjoying it. That's great. So what I might do is, Gillian, I haven't heard from you, so I'm gonna have to find a nursing related question for you. Maybe you can answer Owen's. Should vaccine immunity be absolute? If not, is there an idea of how long a vaccinated person may be able to pass on the virus? This comes from the martyr idea that vaccination does not stop you from getting the virus. Okay, it's a really long question. Sorry, I didn't realize it's so long.
I might pass that one over, sorry.
Okay. Oh, and you're in trouble for asking.
I think I caught the tail end of that, so I'll answer it.
Thanks, Kingston.
We hoped initially that these vaccines would prevent infection. And it looked like the clinical trials were done when the Wuhan strain was still permeating the globe, and then the Alpha strain came along and things changed a little bit, and then the Delta came along, things changed a lot more. And the bottom line was that the protection against the Wuhan strain was pretty good against infection. It was able to prevent infection in most people. But as the virus changed, the ability to prevent infection declined, and we were left with preventing disease. And that's where we are now. Those vaccines that we're using, because the virus has changed so much, are struggling to prevent infection. So in most people, they don't, but they do prevent the severe disease and the high viral load. So a lot of people who might get infected that have been vaccinated will not end up in hospital, and hopefully will not end up in
end up working in ICU. So we just don't want to put them off either, because we need as many students and nurses as possible. Any other questions people want to? Gillian, I'm sorry, you're going to have to find a question for you.
Well, I might just make a comment even.
Please,
just about, I suppose, the importance of the nurse's role in vaccination. And I think it's really been demonstrated over the last 2 years in terms of, all the vaccination clinics were, primarily staffed by nurses, and a lot of my friends were very involved in that. And also in terms of giving information to the general public. So I just kind of want to commend nurses for that. And I know some student nurses were involved in the vaccination clinics as well. So that's just a comment I'd like to make, that really we've excelled, I think, in trying to protect the public.
They are, and they really are working.
Yeah.
Okay, there's loads of questions on Padlet, so I just wanted to let you know. I'm now diagnosed with an autoimmune disease. Quite severe symptoms started a few days after the Pfizer vaccine. Could this have been an adverse reaction? Anyone? Yeah, I know it's a tricky one. Hey,
impossible to answer.
Yeah. Okay. You had DTaP vaccines in your slides, is that the same as Tdap? Okay.
Tdap is diphtheria, tetanus, and acellular pertussis. So that's what we give to our, so we give two versions of that vaccine. There's one that's a higher dose that's given to children, infants at 2, 4, 6 months, and again at preschool. And then there's a sort of an adolescent adult version of it, which is a reduced dose, which is a booster that's either given at secondary school age, or even now in the US, they're giving it to adults. So this is the small P for the pertussis, so the pertussis dose is lower.
Thank you. If you could give one piece of advice or a link to a resource of a parent who is resisting vaccinating their 13-year-old child against Men C, what would it be? They don't trust HSC sources. Okay.
Yeah, I mean, I mean, I don't want to parade my own area, but myself and Dick Oldstrom and Bert Rima from Queen's wrote a piece for the Royal Irish Academy for the public on vaccines, and it's accessible on the. It's not specifically about meningococcus C; it's on all vaccines, and it's designed to sort of give the lay person a sort of an easy guide to vaccination, and it's quite a useful document. So if you go into the Royal Irish Academy website and put in vaccines, it should pop up.
Okay.
If you put my name in it as well, you'll find it.
Okay, brilliant.
If I could add to that, Tracey.
Yeah.
The last 13-year-old I saw with meningitis was a young girl who had her breakfast and went up to her room perfectly well. Parents came up about an hour later, she's collapsed. She was brought into Drogheda from Dundalk within 40 minutes. She arrived in our emergency department white with purple spots all over. She was dead 15 minutes later.
Okay.
Yeah.
So this meningitis is absolutely lethal when it gets going.
Yeah.
And is one of the commoner causes of sepsis-related death in children who are not vaccinated. And it is largely preventable.
Okay. Okay. I've shared that link, and I will share it with my students as well afterwards. So thank you very much for that. There's a lot of questions, but I think I've taken up enough of your time. And what we might do is we might have a follow-up in 6 months' time, if that would be something you'd be interested in doing. Would that?
Sure.
The booster.
Yeah, the booster.
Yeah.
The booster.
I like it.
But I think I love this because you see, even if we got, like, I'm trying to encourage even the students to share the webinar with their parents or family, because they're telling me they're dealing with resistance to vaccines in their family groups and having massive arguments with family groups about not. So the idea was that they would get more information, that they would be able to explain the science behind it, bust those myths about pork products being found and the mercury and all the other scare things that they've the misinformation that has managed to filter through, which is really, really important. Have we time for one maybe more question? Has anyone got any comments? No, I think everyone's jaded after today. Listen, I just have to say thank you so much, everybody, for being involved, for our tech support, Justin, and for Kingston Mills for coming over to talk to our students. It's fantastic. And for Christine, Gillian, and Anthony, so grateful. And thank you very, very much, because I think it's been a really informative session.